I'm saying hello to everybody from Münster, Germany. And we are having today a talk on medical treatment of endometriosis before and after menopause. And as you can see me on the right, although it's an audio, I put up a picture of myself so you can see me, but more importantly, you can see where I sit now, and I'm here in Münster, which you can see here. It's an old German city, and there are not much many cars you can see on the left, which helps to keep us fit and using the bicycle or do running. Now you may wonder why we are not just talking about endometriosis, but also distinguishing between before and after menopause. And the awareness for endometriosis have become much greater in the past years. And with this development, there is a more awareness also for this disease, distinguishing in relation to menopause. Obviously, there are many more patients before menopause with these symptoms, but it's important to understand that there are others around menopause or later. I'm chair at the University Hospital here in Münster, and my interest is focusing on the surgery, but also medical treatment of this disease. And we have a center in Germany of expertise, about 20 centers where you can do major surgeries. So starting with endometriosis, as you may all know, this is defined as the growth of endometrial tissue outside the uterus, which can be located in a peritoneum, but also invading some tissues like rectovaginal septum, also ovary. And usually in almost 99%, this is a benign condition, and it's rarely that it is actually malignant, but there is some relation to malignancy, which we will talk about later. The endometriosis is a frequent cause of unspecific, but also menstrual-related pelvic pain, and it's also related to infertility. This is not fully understood, but it's a major thought when you see a lot of endometriosis, as you can see on this picture on the right, where you can see an endometrioma and some disease behind the uterus and some in front of the uterus. And this is a common feature in women who have serious pain. Now, it's not quite clear how endometriosis develops. Mainly in premenopausal women, it is thought that retrograde menstruation, as shown here in the upper left, where tissue which is shed during menstruation will gain access to the peritoneum intraperitoneally. So it is not a kind of retrograde menstruation where this tissue may adhere to the peritoneum. And if it gains access to vessels, angiogenesis, it may proliferate or even invade into this tissue, may even grow much bigger than here. So it is called the deep lesion or deep endometriosis. And if the surrounding environment is able to tackle that problem, the disease may regress. So it even can regress as far as becoming a scar. So if you look on the right, you can distinguish active and inactive sites. And our present general staging system doesn't really allow to differentiate very well between these kind of active and non-active lesions. But I think this is something very important. So red lesions like here are usually active ones, and the clear lesions, which are even more difficult to see because they are transparent, are maybe also the active ones. Then more visible are the black ones, that's quite clear. And some of the lesions are white, where there is mainly scar tissue, but some other active tissues may be present as well. So having a look by laparoscopy, you may distinguish these different types, and one should document these lesions as they are. Now, let's have a look at the age-dependent distribution of this disease. Now, this is a study published in 2012, where the different age groups are shown here and how many patients have been documented. And you can see that obviously the majority of the patients are below the menopausal age, but there are quite a number of patients who are perimenopausal or even some in the postmenopausal period. And the question is, how can you distinguish that, and what is the relevance of having these different types? So in the first part, I will tell you more on the general knowledge in premenopausal patients, and then in the second stage on the postmenopausal cases. Now, the main symptoms are well known regarding pain. It can be dysmenorrhea, especially if it is long-standing endometriosis, it becomes chronic, and it can be general chronic pelvic pain, not necessarily related, so it can be non-cyclical pain, or there are severe symptoms with dyspareunia, problems with bowel functioning, or bladder functioning. A common feature is that if there is some kind of a scarring around the bladder cannot extend that well. So patients will feel that there is something wrong there. But there can be also obviously invasion into the bladder, and we do a lot of surgery with different types of patients who have more or less similar symptoms, but not all of them are same. And there is another group of patients with subfertility or infertility, where there are not necessarily that much pain, but it is observed that there is some endometriosis while laparoscopy is performed. But of course, a lot of patients can have both pain plus subfertile problems. Now, if we are talking today about the treatment options, one has to see what are at present the actual modalities. And this is a cartoon showing the endocrine axis here, which is key to the understanding on the regulation of endometriotic implants, but it's not the only part. We do understand that estrogens are having a major effect on the implants, but there are some resistance. So even if you treat the implants, there may be some resistance to the medication. And it's important to understand what's happening in the implants in order to develop new medical treatments. Now, it would be important to remove the tissue which is endometriotic by surgery, or treat medically later on, mainly regarding symptoms, but also to potentially prevent progression or recurrence. Now, since we are talking about medical treatment, we would like to understand which women need medical treatment. So once, for example, surgery is done, or even before surgery, that would be something important. Now, let's concentrate first on post-operative therapy. And it's interesting to know that about 20% will have no relief of symptoms after the operation. So that's obviously a main group where patients will ask for further treatment. The long-standing endometriosis will usually develop in a recurrence of symptoms in quite a number of cases. So up to 50% of patients will actually have, again, symptoms, even if they have been treated perfectly well by surgery. And that's a very important group. And the third problem is that the pain score not necessarily relates to the stage of the disease. So it is very difficult to tell from just looking at the stage of disease how you should treat patients after surgery. The main thing is that patients who do not have pain but are suffering from infertility or subfertility are generally not treated by medication. and this is internationally accepted. Now, if you look at our own cases, we have done a study in 2016 and looked at our cases in 1 year. So we have got a big endometriosis center where we have seen just above 1,100 patients who we have done surgery on in 445 cases. And as you can see from there, there's about 69% of these patients have been also treated with hormonal therapies later on. So it's quite a significant amount of women who need medical treatment after surgery. Now, what kind of options do we have? Now, as you know, we have quite a list in the past years. Analgesics, which most women would start on their own anyhow, but most of the others are endocrine dependent. So GnRH analogs, agonists or antagonists. In some countries, you add some add-back therapy. So once you use GnRH analogs, which has been the gold standard in our country maybe 20, 30 years ago, that is usually has a certain limitation because women suffer from hormone withdrawal symptoms, and add-back therapy will be helpful if you do a small amount of estrogens or progestins. That could help. Now, very common is the use of progestins. In our country, Dinogest is licensed to use for that indication, but also oral contraceptives are very commonly used. In generally, they are used as a long cycle. So uninterrupted administration of oral contraceptives are generally thought as reasonable because you will have avoided menstruation, so you avoid the pain of menstruation, but also possibly the retrograde menstruation, which is one of the hypotheses to develop endometriosis, will be somehow useful to have oral contraceptives. Now, danazol has been used a lot, but not that much anymore in Europe. And in some countries, some doctors use it, but it's generally not used because of their side effects. In some women who either don't want to take these medications or have additional adenomyosis, often levonorgestrel IUDs, in our country, Mirena, is used. In the past few years, aromatase inhibitors have been tested because aromatase is upregulated in endometriosis, and the use of inhibitors of endometriosis may be quite helpful. I will talk a little bit more about that in a few slides. Now, the question is, if you use OCs, can you tell your patients that if you do use OCs, you will prevent the disease? I thought many years back that that is the case. Unfortunately, if you look at this big study published in 2011, it's actually, this could not be shown. So if you look at the patients who've been past users, so the ones who've been using oral contraceptives beforehand, they had actually higher risk of having endometriosis than those ones who actually did not use. So the problem is, I don't think that actually the oral contraceptive necessarily make endometriosis implant, for example, or something like that. I just think that women taking oral contraceptives don't use that much surgical therapy because they have pain relief, but the disease may progress. So that's the current understanding of that data, that prevention of the progression of endometriosis is possibly not easily done by oral contraceptives. So what kind of progestins do we have? You can see a long list in this that varies from country to country. For example, Dynogest is licensed in Germany. The other ones are actually not licensed, but are commonly used. Um, and licensed drugs are reimbursed in my country. So this is one of the reasons why this drug is also used more than some others. Now, how can you compare the effect in premenopausal women if you add Dynogest or GnRH agonist? And as you can see from this slide, if you give GnRH analogs or Dynogest, you have basically the same effect regarding efficacy in reducing pain. So VAS score, as you know, depicts how much is perceived or how is the perception of that pain by patient themselves. And you can see that the decrease is pretty much the same with both drugs. So it's a bit surprising, although the mechanism of action is different. So you can use actually both to have the same effect. As I said before, some women prefer to use IUD. It is regarded as quite equivalent to GnRH analogs because some of the endometriosis-related pain may also be related to adenomyosis, which I believe is also the reason why IUD has quite a good effect. And this is linked to less bone loss than GnRH analogs. So there is some advantage of using steroids. Special indications are, as I said, adenomyosis for IUD, and there is less systemic side effects. So if other hormonal treatments have side effects which are not tolerated, then one can think of using that. The question is, can we use it also in postmenopausal women? There are some who use that, but that's quite rare, and there are no really good studies to decide if that's really something you should be doing more often. It is more regarding aromatase inhibitors, which are possibly of greater help in postmenopausal women. And the reason for using aromatase inhibitors is mainly because there is an increased production of estrogens in the endometriotic lesions themselves. So since these lesions often have aromatase enzymes, they are able to produce more estrogens themselves. So it's not the systemic estrogen I'm talking about, but the locally produced kind of intracrine or paracrine production of estrogens. So the use of aromatase inhibitors makes sense in a way to somehow directly affect the estrogen production of endometriotic lesions. And using that in some studies, it has been shown to reduce lesion side, also reduce pain, and also reduce some other complaints regarding bladder or the bowel. Depending on in which group of patients, sometimes it's used together with micronized estradiol to alleviate some symptoms, and also some bisphosphonates if you use it long term, because aromatase inhibitors will obviously reduce bone density, and just as in oncology, bisphosphonate can be helpful. Now, using aromatase inhibitors can be done both during postmenopause or after menopause, but also in premenopause. And the mechanism, how it works, is shown here. So the basic is about the same. So you have endometriosis with aromatase activity, which you want to block by aromatase inhibitors. But the feedback mechanism is obviously different in postmenopausal women. So using aromatase inhibitors will not interfere much with the feedback because there is no effect on the aromatase of the ovary, and since there is no activity or not much activity there, that means that you can use aromatase inhibitors in postmenopausal women who have endometriosis without having the fear that you have interfering with the feedback mechanism. Now that's quite different in premenopausal women, obviously, where there is an intact feedback mechanism. If you add aromatase inhibitors, central upregulation of FSH and LH will occur, which stimulates aromatase activity in the ovary. So inhibiting aromatase in the endometriosis will lead eventually to upregulation of aromatase activity in the ovary and in increased steroid. So that's counteractive, and therefore using aromatase inhibitors in premenopausal women requires the addition of other drugs like contraceptive to block the feedback mechanism. So GnRH analogs, progestins, or contraceptives will block that. That's a little more complex and complicated. So I believe that aromatase inhibitors are preferentially used in postmenopausal women rather than in premenopausal, which is more complex. Now, looking at the medical treatment throughout the world, or at least in Europe, I can show you here a slide which is from a study called VIPOS, or the VIPOS, where all the different agents which can be used in endometriosis are listed on the top. And some countries where it has been looked at what is the percentage of use. And as you can see, for example, for Dynogest, this progestin is used very differently in different countries. It can be anything between 7% and 80% of all the treatments. So in some countries like Switzerland, this is the major drug to use, and it's also quite high in some other countries. And this may be the reason why some other drugs are much less. So for example, danazol, which I showed you, is in some countries virtually none, just like in Germany or in other countries, but there are some, for example, some countries, they're still using it. Oral contraceptive is generally used in many countries, but here is again a large variation. Switzerland 11%, Hungary 84%. So it's a huge difference between different countries. So talking about medical treatment relates also the ability to use these drugs. There can be many reasons for deciding what drug to use. Mostly what drugs are available, what drugs you can pay for, and what kind of drugs may be reimbursed or not. So there are many other reasons other than just medical reasons using the drugs. Now let's talk about postmenopausal endometriosis. Now, since most people think endometriosis is insulin related, that can only occur way before menopause. Now, that's quite true for most of the cases, but there is a reasonable number of cases during postmenopausal periods or around the menopause, and that is much more difficult to distinguish because there are other factors which may interfere. Or just like in postmenopause, there is no cyclical problem in all cases. So that may be much more difficult than during premenopause. So diagnosis is a problem. There may be several reasons which can additionally promote the development or recurrence of endometriosis, such as use of exogenous hormones or ovarian remnant syndrome, where you think the patient is postmenopausal, having removed the ovaries for some reason, but if there is some ovarian tissue left, that can still produce estrogens, for example, and there can be some endometriosis-associated symptoms which are quite difficult to distinguish. So I've taken from the literature a case which I thought is quite impressive. A patient who was documented being 53 years old with no prior hormone therapy. And this case has been published in Fertility and Sterility quite a number of years ago. With a patient had a BMI of 36 and low estradiol levels corresponding to the postmenopausal situation. And the patient had initially a complaint of hematuria, and then on workup, it has been seen, as you can see from that magnetic resonance imaging, that there is a remarkable hydronephrosis caused by a large mass, as depicted here. Now, to make the long story short, the surgery has been done, and removal of parts of the bowel. You can see the large endometriotic mass in this postmenopausal patient. And there is a number of other reports, and I believe that there's much more postmenopausal endometriosis than we believe, because many of that disease is not expected to be endometriosis, and sometimes it's not easily determined. And if it's a benign lesion, there is maybe not so much investigation in addition. But as you've seen from my table and cartoon before, there is a reasonable percentage of women, like around 5%, around the perimenopause, and maybe 2 or 3% postmenopausally, who have endometriotic symptoms. So what shall we do? Now, the management is, in general, during postmenopausal or perimenopausal, if there is a symptomatic endometriosis, then surgery is first line. The main reason being that usually, as you've seen from the slide before, a pelvic mass in postmenopause causes usually a diagnostic uncertainty. So we don't really know what it is and whether there is a risk that is malignant, or maybe there is a kind of associated malignancy, as I will show you later. And the question is there also potential malignant transformation? So that will be the best to remove that tissue and have it histologically confirmed. It usually also relieves pain, and that's probably the best best line of treatment initially. The question, what should we do and what kind of medication patients can have who have endometriosis? Of course, analgesics, but also progestins. You can use progestins, have a direct effect on endometriosis, although there is some kind of progestin resistance. This is actually also a kind of definition of endometriosis, having some kind of resistance to progestins. So not all patients will actually have an effect. As I showed you before, aromatase inhibitors may be a good idea to use, and the drugs which we use during premenopause, like oral contraceptives or generation analogs, they are not used by themselves, so that's not recommended. Now, once patients have endometriosis diagnosed either during premenopause or even postmenopause, the question remains, can you actually give those patients hormone replacement therapy in order to have all the benefits of hormone replacement therapy? Now, there is always a fear that HRT may actually reactivate potential residual endometriosis. So that is not necessarily clarified yet. There is still some thoughts that just giving estrogens may not be a good idea. So generally, out of that fear of having reactivation of residual disease, it's recommended to give progestins in addition to estrogens, even in women who have had hysterectomy. So in addition, there may be also some effect on new implants around menopause, and also the question, does hormone replacement therapy allow for an enhanced transformation of endometriosis tissue to become malignant? It's still not clear, and there are no really good studies to decide that question. So women who have a history of endometriosis should have a certain discussion about the use of HRT, especially in women who have premature and or early menopause, with the risk of an enhanced overall mortality, cardiovascular disease, etc. So the final advice is there should be some thoughtful HRT management in those women as well, and not just saying endometriosis doesn't allow to have HRT. So that's the general recommendation. Now, what happens with HRT regarding recurrence and malignancy? And there are some studies showing that there is a potential risk of the transformation of endometriosis lesions, and this can be actually more severe in women after menopause. And there is also some data that HRT may have an effect on recurrence, and if there is some malignant transformation in general, the tissue is kind of endometrioid adenocarcinoma type. Now, why is there a risk of malignant transformation? The main reason being is, as shown in this cartoon, that the actual mutations of oncogenes or at least genetic changes are quite related between endometriosis and ovarian changes regarding malignant changes. So if you look at the different tissues, you can see similar mutations both in endometriosis and ovarian tissues. So there may be already some kind of risk in endometriosis in general. But that's not to say that a majority of women are at risk to have malignancy, but that's the explanation of that kind of malignant transformation. And if you look at epidemiological studies, it has been shown that there is a risk of endometriosis-associated cancer in endometriosis patients, and that's up to 2.5%. And that's with regard to endometrial cancer, ovarian cancer, generally of low grade serous type, and there can be endometrioid invasive cancer, but also clear cell cancer. So some of them are rather bad type of cancers as well. Now, malignant transformation of endometrial tissue has been investigated, and it has been shown that some of the genes are downregulated or upregulated, and these genes are involved in some kind of malignancy or malignant transformation. Now, there is a certain fear that if you use hormones in women, especially in young women, that you may actually promote that kind of changes. And a very recent study shows that this is only the case if you have endometriosis and you have ART. ART itself, in other cases like PCO, etc., will have no increased risk. So the risk is the same as controls. Whereas ART-treated women who have endometriosis may actually have some increased risk. Now, this is a study which shows actually a remarkable increase. So we have to probably wait for further studies to tell us what we can do best in these women who are also suffering from subfertility. So what are the present recommendations? If you look at the EMAS position statements, how to manage women with a past history of endometriosis, you can see that that's from 2010, and the recommendations are about the same as I showed you before, that estrogen-based hormone therapy is required in women with premature and early menopause, and that's stressed here because women who have had their ovaries removed due to severe endometriosis do need to have some hormonal treatment, and especially if they are at young age. So in general, the recommendation is to use continuous combined estrogen progestin therapies, both in hysterectomized and in non-hysterectomized women. And that's the main difference from general use of HRT. So it is recommended to add progestins even in hysterectomized women as well. There is a long list of preparations, herbal preparations, but there are no real recommendations to use it. Actually, it is not recommended because the estrogenic compounds in these preparations may have some effects which we don't know. So we do not recommend from EMAS to use these. And if you look at the approach published in a different paper, you can see that there is some change in the past years that endometriosis should be thought of during menopause or after, especially in women with a past history of endometriosis. And one should be aware that there is a possible risk of malignant transformation, although this risk is quite small. And one should watch out for the different risk and benefits ratios when using HRT. And as you can see from this publication, it's quite close to these recommendations given by EMAS, shown before. So one of my final slides is to conclude that for women who are in premenopausal condition, can obviously use various type of drugs which interfere with hormone production or hormone action. During postmenopause or perimenopausally, progestins are often used, but also recently aromatase inhibitors have been suggested. And I have pointed out that in individual cases, this can be used in conjunction with other steroids during premenopause. So the question of HRT in women with menopausal symptoms and the history of endometriosis, the recommendation is to use HRT if required, both with estrogen plus progestins, even after hysterectomy. So as you can see, there's a lot of different aspects, and if you would like to read more about it, we are working now on the update version of this ASHRAE guidelines, which is online since 2014. And this year we're hoping that we'll have the updated version, which you can look up. And this is a major event to produce these new guidelines by ASHRAE. So as you see, endometriosis can be very complex. It's a difficult field to tackle, not just those who would like to play football on the hill, but endometriosis itself is quite complex. So I hope you are now able to understand a bit more the difference in different stages of endometriosis, and I'm looking forward to your questions, and this is the end of my talk now. Thanks very much.
Thank you, Doctor, for such a wonderful presentation. And now for the QA part, we will wait for a minute.
Okay.
Well, it seems that we do not have any questions for the moment.
So maybe everything was clear from
Yes, I imagine. So, well, this concludes the webinar. Thank you so much, Dr. Kiesel, for your presentation. And all the, oh, sorry, there's one question from Walter Jager. Does your message also count for postmenopausal women with adenomyosis?
Yeah, that's a very good question. Adenomyosis is often with endometriosis, and we believe that many features are similar, and also treatment is very similar. But there are not very good studies to distinguish adenomyosis from endometriosis. So in general, we suggest to use the same drugs. There is some tendency to use the Marina in patients with adenomyosis, or at least additional adenomyosis. So that's mainly the difference, to use more the IUD with hormones.
Okay, so we'll wait for a minute more, just in case. Walter Jager says thank you.
So,
well, I think that this concludes the webinar. Again, thank you so much, Dr. Kiesel, for your presentation, and all of the attendees for being here today. Have a great rest of the day.
okay, thank you.
Thank you.
Bye.